The first case is that of a 37-year-old female. This is a patient of Dr. Colgan's who presented with a left ovarian mass. In November of 2018, she had the onset of left lower quadrant pain with menorrhagia. An ultrasound was performed, which revealed an abnormality. She had surgical removal of the left fallopian tube and ovary, and she came to the Mayo Clinic Lymphoma Clinic on February 19th, underwent a bone marrow and a PET scan, which we will see. Her past medical and surgical history are non-contributory. Her physical examination was unremarkable. Her laboratory studies were unremarkable, with the exception of an elevated AMC at 660. Could we see the radiology, please?
Greg Wiseman from Radiology Nuclear Medicine. The PET scan we have from the 20th of February, and don't see anything on the rotating image there. No nodes or anything. Spleen looks good. So in the pelvis, then she had the left ovary resected, and you can see there's a little uptake on the right, which in premenopausal we frequently see uptake in one or both of the ovaries, and so this looks like it's a physiologic uptake on the right ovary. That's all we saw.
Thank you. Can we see the pathology, please? Dr. Curtin.
Paul Curtin from Hematopathology. So we received the left ovary and fallopian tube to review. This is the ovary specimen. You can see that the architecture of the ovary is effaced by an abnormal lymphocyte population that's growing in nodular patterns down here that's quite distinct, and more vaguely nodules up here which coalesce with one another. The cell composition of the nodules you can see here is somewhat varied. There's not all large cells and not all small cells. And when you go under higher power, you can see a mixture of large centroblasts and smaller centrocytes within these nodules. When you count them out, the centroblasts constitute greater than 15 cells per 400x field. Here's the phenotype. The cells are positive for CD20. They lack staining for CD3. They're positive for the germinal center B cell marker BCL6, negative for CD10, negative for BCL2, and show focal immunoreactivity for CD30. So this represents a follicular lymphoma grade 3A involving the ovary only, not the tube.
How unusual is CD30 stain in follicular lymphoma? You guys don't tell us about that too often.
We don't stain for it that often.
Yeah, I agree.
But it's in the literature, and they talk about a subset of large cells within follicular lymphomas of various grades being CD30 positive. So I think it's not an unexpected finding if you go back to the literature, but as Bill says, we don't interrogate that in our own practice very often.
Okay. Yeah, that struck me. So this woman had stage 1AE disease, grade 3 follicular lymphoma, and she's post-resection, so how should she be managed? Just put together a laundry list there. To start with, I think one of the interesting things about her is she does fall into her absolute monocyte count was 660, so that's elevated, and that's the only unfavorable prognostic factor she has. If you look at cause of death, and I think when we think of patients like this, if we begin with the end in mind, that this is a good exercise, an important one to do. And when we looked at all comers in a U.S. and French combined series, which just came out in JCO, the cumulative incidence of death from lymphoma at 10 years was 10%. So it's kind of an easy number to remember anyway. And as a result of lymphoma was higher as a result of all other causes for patients who fail to achieve an EFS24 and for patients with a history of transformed. So the EFS24 and transformation are important issues. There are no differences in the two different data sets. This was the cumulative incidence by cause of death, less or equal to 60 in the left upper quadrant there, 61 to 70 in the right, and then in the bottom greater than 70. And so her risk of death is low, but when you look at all these curves, you can see this only goes out 12 years, and she's 34 years old, so it's not quite as meaningful as it is in someone in their 60s and 70s. And then this was to the right, the the lymphoma-related deaths, and looking at the EFS24 data, time since EFS24, and then time since early events. So demonstrating that if you've got an early event that is less than 24 months, and that curve on the right, that's unfavorable. And this is further looks at the risk of cause of death in the two age groups. The PRIMA PI, we participated in that study, and that just came out in 2018, looking at just two factors, the beta-2 microglobulin and bone marrow involvement. She did not have marrow involvement, and the beta-2 microglobulin is normal, putting her in a favorable prognostic group. And these were the curves. And again, how helpful is this in someone 34 years old? You could really ask some very hard questions. And in the PRIMA study, half of the patients receiving rituximab maintenance remained progression-free at 10 years, which Gilles Solis queried whether or not, when this was presented at ASH, whether or not we're actually curing a segment of patients with follicular lymphoma in that subset. Obinutuzumab as first-line treatment, that's an option if you want to really be aggressive potentially, but only an improved progression-free survival. And with bendamustine, just to remind us all in the Gallium trial that the bendamustine arm regimen-dependent deaths were 4.2% versus 1.2% with CHOP and 0.7% with CBP. So we'll open this case up for discussion about approach to get back to Dr. Colgan.
Another approach as a stage 1E and consolidated with radiation and immunotherapy.
Option? Or radiation therapists are not here this morning. Usually they're here. Joe did discuss this with radiation therapy and elected not to. That's an option.
I mean, if you radiate her, give her alkylating chemotherapy, she's been referred to reproductive endocrinology. Between 34 and 37, she's at risk for drastic drop-off of endocrine reserves, and she's half down anyways. I mean, I know they have evidence that one ovary picks up the slack, but if she still wants kids, she's on the border.
She started her family very young, actually, high school. And so she was not interested in pursuing further children, but we still get into the issues, so I'll take your point well, because we still get into the issues of metabolic bone disease, so osteoporosis.
I think there's been some articles about ovarian, mostly large cell lymphomas as a primary site, right?
It's large cell, yeah.
Yeah. Did you find any folliculars in those
There's
series?
not much out there.
Yeah.
I tried to look at this a couple times, and the whole Mayo experience, actually, we went back into the we went back into the 40s, no less, and we came up with like 110 questions, 110 to 120 cases or so with pelvic-only involvement, so the 1AE thing, and it was such a quagmire and such a broad time period that to really say anything very meaningful, I just thought it wasn't worth the effort. There's Farrell, question?
Yeah, I do have two questions. Number one, to the pathologist. So this is a CD10 negative, BCL negative, a follicular cell. I was ready to hear from you that it is diffuse large cells. So I was wondering, what's the percentage in your experience of a follicular CD10 negative? BCL negative. The second question, the data that presented is mostly all comers, not a stage 1E, as I believe this is a stage 1E. And surgery or single modality radiation, it might give the patient a very prolonged disease-free survival, and probably should have a better prognosis than what is presented.
With respect to the pathology, about 10% of follicular lymphomas are CD10 negative, and about 10% are BCL2 negative by immunohistochemistry. the higher grade follicular lymphomas tend to be the ones that lack immunoreactivity and rearrangements of the BCL2 gene. And so I think that those findings aren't that's what's in the literature, so I think that the findings in this case are not incompatible with what's in the literature with follicular lymphoma grade 3A. We were able to I didn't show it here because the stains were no longer available to us, but there were CD21 positive follicular dendritic cell meshworks associated with the tumor nodules, and the BCL6 was a pretty good marker for germinal center origin, given everything else in the case. So we were pretty confident that it was follicular lymphoma rather than diffuse large B-cell lymphoma.
I think the radiation therapy question is a very reasonable one, and I'll get back to Joe on that. Are there other thoughts and comments?
If she had measurable disease, I think this would be a great candidate for the Zevalin versus Rituximab trial. But without measurable disease, I don't think she would qualify.
She had no disease, yeah.
I would lean towards observation and treating when the disease recurs.
How many would vote for radiation therapy?
If possible, yes.
So it sounds like,
But it sounds like it's not
you decided
possible.
no, the radiation oncologist, the patient.
Well, no, but just no. I think this is a fruitful discussion because it's just two people discussing the case before, so we have a broader audience. So, how many would favor observation?
If radiation is not an option.
Not enough.
So there's more favor approaching radiation therapy. That I'll get back to Joe with that.
Do you know, Tom, in the primary ovarians, is there a tendency to relapse in the other ovary? Is there any tropism?
I wasn't able to
Thinking of it
find
like
much
this.
in follicular disease. Yeah.
Sometimes these extranodal things, it's homing to site, and it would go to the question of if you're going to do radiation, what's the field?
Well, it's like the parotid. I just went through a bunch of stuff for the workshop for the LRF and marginal zone last night, and parotids have a real predilection to go bilateral.
Yes.
And so that's a great question here, and I just wasn't able to dig up much on this. I didn't spend as much time as I sometimes spend, but there just isn't much out there on this specific case with these specific details.
If you knew this lymphoma had a MUM1 or IR4 translocation, which would tend to be associated with a better outcome, would you think differently about adjuvant therapy?
I'm not sure I would. Would anybody else? I don't think I would.
I don't think we have the data.
Yeah.